Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hard-working Americans and their families?
You will! This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefits in your benefit plan. Now prepare to learn,
Plan,
save,
and protect with the FIA Group.
Welcome to another episode of Empowering Plans. Today you have myself, Kelly Dempsey, Vice President of the Consulting Department here at FIA, along with Bryan Dunton, one of our health benefit plan attorneys that works and specializes on the area of the NQTL comparative analysis. It's definitely not all he knows, but he definitely is our in-house expert on all things NQTL. So today we are going to talk about the 2024 report to Congress related to mental health parity. And the focus of this report was definitely network adequacy. So as the result of the Consolidated Appropriations Act of 2021, regulators have to supply Congress with this annual report detailing their enforcement efforts and the compliance trends related to the non-quantitative treatment limitations, the NQTLs, in group health plans. And when I hear the word network adequacy, I'll play on my own innocence here that when I think of that, I think it's just the number of providers. And in preparing for this podcast, Bryan has enlightened me, as I hope we can enlighten you, as to what network adequacy really is, because it's so much more detailed than just the number of providers. So Bryan, I'll let you add whatever you'd like to the intro here of what else can we expect in this podcast.
So we can expect a few things. Really, network adequacy is indeed so much more than just the number of providers. It's talking about provider credentialing procedures, so how they become part of the network in the first place, how reimbursement rates are decided, what the network vendors themselves are doing to ensure that there's adequate access to care for plan participants. Those are all really important components of this. And it's been a constant area for deficiencies to arise during NQTL comparative analyses. And that's something we've seen here at FIA. And it's also something regulators have noted consistently year over year. And I think it's really important to note and remember at the beginning of this that even though network concerns we'll discuss today may not be the result of decisions made by the plan, rather it's from the network vendor themselves, the plan is responsible under the Mental Health Parity and Addiction Equity Act for both the NQTL testing and ultimate compliance. So if there is a compliance problem that shows up, plans really need to be proactive about finding a way to address it.
Yeah, that totally makes sense. So, we've looked over the report. Obviously, this is a very detailed report that comes out, and there's all these surveys that they conduct about the network adequacy and the directories and how effectively patients can access care. So how quickly they can get an appointment. To me, this brings back memories of all of the conversations and things that were in the headlines a few years ago related to the VA hospitals and the fact that, unfortunately, patients were actually dying in the ER waiting for care because of the delays in getting people in, the lack of providers, and just the lack of resources that our VA hospitals had. So this was what triggers my mind when I think about this network adequacy and whether or not they can get an appointment. But I know in the report that it talked about EBSA conducted 9 random surveys where they called more than 4,300 outpatient providers listed in various plan network directories. And the results were really crazy that a lot of providers were just totally unresponsive. They couldn't reach them, they couldn't get through, or they weren't actually providers anymore. They were either retired or they had closed up shop despite being listed as active. So, and I can understand the trouble to maintain these databases because it is challenging when you're trying to track and maintain all the things. It's the same struggle. It's the same themes we see along other areas of our industry and other things, like just updating and maintaining a plan document is super challenging. So the fact that, they can't maintain their provider databases, not hugely surprising that there would definitely be, errors in there, but just the amount of people that didn't respond was really kind of crazy to me.
Yeah, I think that's a good takeaway for this. And I think it was really important to note that the rates across the board for actually being effectively offered some type of services that the caller was inquiring about in the first place, they're really low. Mental health substance use disorder providers had an 8 to 28% range for actually being able to offer that kind of care that they were looking for. And medical surgical providers were 24 to 37% across those surveys that the EBSA did. So I think the big takeaway is both of these numbers are just absurdly low. I think everyone really hoped they're significantly higher percentage wise, but even taking that into consideration, an 8 to 28% number, it's a really wide stance here where there's just not consistently callers being able to get what they're looking for. And I think that does have a negative impact on plan participants.
I mean, I can openly say myself that when I know that there's something bothering me and I need to go see a doctor, I sit there and I think about, okay, who do I even need to go to? Do I start with my primary care doctor? Do I start with just calling the specialist directly? And I don't know which specialist to call. So I can completely understand when I see these numbers that were shared. It's startling. Even from the medical surgical side, it's startling. And I know that we've talked about the number of active investigations. So as a refresher, by law, the DOL is required to have at least 20 active investigations related to the NQTLs open every year. Now, we know that these investigations take a really long time. And we know that from the recent report that there were 25 active investigations specifically relating to network adequacy. So that's clearly more than the minimum threshold of 20 total. And this is only 25 that had network adequacy, which means there could still be a significant amount more open. And that's just, it's kind of startling that number was so high related to network adequacy. But like you said, in the work that we've been doing, this issue is showing up more and more often that we weren't necessarily anticipating.
Yeah, and I think another really interesting takeaway from this report is that regulators have said that the NQTL comparative analysis itself is great to have. It's obviously necessary. It's required by law, but they're kind of viewing it really as just a starting point. They really want to see a more granular review, and the NQTL comparative analysis, as deep as it is, doesn't necessarily always help them understand the discrepancies between written procedures and operational results.
Yeah, that's obviously assuming that a group has the comparative analysis on file. And I will say in the conferences that I've attended over the last year, and I just think from our own, service offering that we have related to the NQTL comparative analysis, we've obviously seen a significant uptick in the amount of groups that are starting to request this and realizing it is something that they need to take seriously and they need to have on file. Because the common feedback that I received when people came up to me because of the places that I spoke, the mix of audience of what they thought and what they thought was required was really kind of interesting to me. That there were a lot of people that were taking the position that, without the lack of directions and guidance and without a template available, that they were, not taking action yet. They weren't doing the comparative analysis. But obviously, as we get further and further into the effective date of the requirement to have one, I think it gets a little bit more and more dangerous every year to not have one on file. And it's very challenging to determine what your problems are and how to solve them if you don't have the report in front of you.
Absolutely.
So, when we talk about network adequacy, that we can dive a little bit deeper, I think we can peel back the layers of the onion and look at what really is network adequacy if it's not just the number of providers. So what else are they looking at when we say there's network adequacy concerns? What else is involved?
So the EBSA, the enforcement arm for the DOL, they're really looking at the following kinds of network concerns. They've focused on out-of-network utilization and outcomes reflecting that access to care. They look at provider availability, plan coverage provisions. They look at timeliness with which care can be provided to a plan participant, the actual presence of providers that have an appropriate area of expertise, too. It doesn't necessarily do a participant any good if they don't have a provider available that specializes in what they need. So that's a key thing too. These next two are really big ticket items, and that's reimbursement rates for the providers and member complaints. Those two in particular are the main drivers of audits from the regulatory authorities. Member complaints are usually centered on limitation or denial of benefits, and certainly from the reimbursement rate perspective, that's driven by providers being dissatisfied with whatever they're receiving in exchange for the services they provided to the plan participant. So those are really big red flags for regulators. There's also kind of a catch-all category, which is extremely broad and basically is whatever else the regulators deem necessary to go into more in-depth analysis and determine if there is some kind of parity issue at play or not. And they're going to ask the plans and their vendors, like their network vendor, to justify whatever those discrepancies are if they exist.
And I think, coming from the lawyerly perspective of it depends, I feel like there's always got to be a catch-all category, right? I mean, that's just kind of how we operate. So, it looks like they're really trying to drill down on parity and access to care. And, I read that in a lot of these situations where there were disparities in the reimbursement rates with really no reason, no ability to explain what happened and when written policies were otherwise lacking that parity. I mean, it's not surprising to me as, it's crazy when I think about it that I've actually been in this industry for 15 years. And I started before healthcare reform was passed. And when I first started, the concept of reference-based pricing was becoming a really big area of discussion. Not a lot of people were doing it yet, but a lot of people were talking about it. So a lot of the research when I first started the industry was related to reimbursement rates and what, the cost to charge ratio. And I always found that the information and the data that was available really interesting. And I feel like we're still in the same place where we're trying to figure out what those reimbursements rates are. And it's very startling to me of the discrepancies between the different types of providers. And I guess I just wouldn't have thought that that would be the case at this point.
Yeah, I think that's a great point. And regulators don't look very kindly. They look very unfavorably upon when there is some kind of discrepancy in reimbursement rates. When you look at everything in writing and it appears like the same procedure should be applied across the board, and that's just not manifesting itself in reality on the operational side. They've also been really dissatisfied with any kind of overly generic rationale. They want specifics pretty much at every step of the process now.
I mean, that doesn't really surprise me when you talk about market dynamics, supply and demand, bargaining power, like those types of things. They're not really sufficient, are they?
Probably not. Regulators have indicated that they're going to view that pretty skeptically. And even citing the things like provider shortages isn't enough. They really want to know what you're going to do.
Yeah, and that makes sense. And I think that's the question that everybody comes to us for is like, how do we answer that question? So, I know other things that have shown up in other problems that have shown up regularly are that, participants are going out of network more often for mental health and substance use disorder services than the medical surgical. The tracking of pediatric care mental health providers is different compared to medical surgical providers. The different distances that people have to travel to access these providers, as well as the different standards for how many providers are available per plan participants. I'll be honest, this isn't something that ever crossed my mind of that a network would be required to have a certain amount of providers, like one OBGYN for every 500 participants or one psychiatrist for every 3,000 participants. Like that information just never even crossed my mind until we started preparing for this, that those would be the types of things that would be required. And it's like, who comes up with these numbers? Like, where does that come up from? It just seems like such randomized numbers. And I'm sure there's based on data, but this just gets my gears turning to start asking more questions. Kind of like when we started talking about how we were going to do this podcast, I feel like all I did was ask you questions, which, that's what we're here for. So back to the point, there's things that are continuously coming up, over and over again with the special and ambiguous standards for the medical surgical providers, but you're not using the same standards for the mental health substance use disorder providers. It all just seems so crazy that these are the things that they're uncovering. And I mean, I guess I'm not surprised, but it's really interesting that this is so common. And I'm just curious, like, this is obviously things that we're seeing when we're doing the NQTL comparative analysis, right?
Yeah, this is pretty consistent with some of the problems we've unearthed over the last several years as well. I think it's important to note that there's nothing saying that, these network vendors can't use some kind of standard type of provider to number of plan participants, but those numbers, those thresholds, they have to be, they have to be similar. They basically have to be the same or skewed probably in the favor of the mental health substance use disorder providers to make sure that there's some kind of parity, that there's adequate access to that care. So just the fact that there is such a large discrepancy when we're finding them is concerning.
Yeah, so let's switch gears and figure out what can a plan do to fix these problems, because that's obviously the next question is, now that we've identified there's a problem, what's the solution? So obviously making sure their comparative analysis is up to date and realizing that not only do you need to have one, you're actually supposed to update it annually. Every year we get new plan data. So it makes sense that this is something similar to like a plan document that you have to update on an annual basis, which is challenging because the amount of time it takes to gather the information and gather the data. Updating the report, obviously, again, it's easier once you have it to continue updating and maintaining it, but it's still a struggle. But what else should plans do when they find problems within their networks?
So as we alluded to way back at the beginning, I think plans really need to be proactive about this. Communication with their respective network vendor is going to be key. For example, during testing, reimbursement rates for mental health substance use disorder providers are lower compared to medical surgical providers. It can be a red flag, and plans should ask why that's the case if standards are otherwise the same on paper. Along with that, when talking to their network vendors, they need to make sure that the vendor works to identify and close these kinds of network gaps. That usually involves some form of ongoing network composition review And that involves looking at things like utilization data, appointment wait times, out-of-network provider utilization rates, because you don't want too many people going out of network to receive care. Kind of indicates that there is some kind of deficiency within the network itself. And really, along with that, plans should be encouraging their network vendors to conduct some kind of targeted recruitment for whatever kinds of providers there are not enough of within the network. And I think the last point here would be to also make sure that whatever providers are part of the network are actually accepting new patients. That's something we've noticed too. Even when the numbers are comparable, there's not always the same level of them accepting new patients, which creates its own subset of problems, again, with access to care.
Yeah, so there must be things that plans can do on their own to address some of their network shortfalls. Obviously, there's a lot that the network is going to have to do to help support, the plans that they service, but what can the plans specifically do by themselves?
So there's a few things that plans can do. They have some options right away. Regulators have suggested that adding a live support option for participants to kind of call into or write into if they have trouble locating in-network care can be helpful. Another option is arranging for the plan to change its provisions to pay for out-of-network care at in-network rates when there's no in-network provider available to help the participant. One of the ones we've probably seen the most is a lot of plans opting to expand telehealth services to increase access to mental health and substance use disorder providers. Just another way to really shore up your network access. Regulators did have an interesting suggestion here in the report this year to Congress, and that was suggesting that plans solicit proposals and evaluate suitability from other networks or network administrators outside of whoever their current one is. But really, I think we view that as something that a plan should only consider in the most egregious cases, when their network vendor they currently have refuses to work to resolve any of those deficiencies that might have come up during a report.
Yeah, that makes sense. Actually, I had a conversation last week with someone about the telehealth and how, when the first vendors that entered the market at this point, well over a decade ago, that they didn't provide any sort of mental health telehealth services. It was truly just medical surgical type stuff. So, rashes, burns, spots, whatever, bites, things like that. Like there wasn't any type of mental health services available for a telehealth provider. So I think the world changed significantly for all of us anyway 5 years ago. And, with COVID, it became a necessity to be able to treat other types of conditions, not just medical surgical conditions, but mental health conditions as well in a telehealth setting. So I think that whether we like it or not, that also kickstarted, at least having more providers that were potentially able to access in a telehealth. But I do still think that there's probably a significant disparity compared to medical surgical providers that you can access through a telehealth setting. So, well, this has been so great, so much good stuff. Any final closing comments that you want to add in here?
Yeah, I think to really wrap this up, it's really important to make sure that plans are ensuring adequate access to care and that they're removing any kind of arbitrary barriers that there are to mental health or substance use disorder care. In this case in particular, we're talking about networks today, how they credential a service provider, reimburse them, and determine sufficient coverage over a geographic area, for instance, can have a significant impact on accessibility to medically necessary mental health or substance use disorder services for plan participants. So even when a plan offers robust coverage for those services, if there's not enough providers available or they're too far away, for example, those individuals just don't have that comparable access to care. And that can result in a host of compliance concerns for a plan that are just as bad as outright exclusion of certain mental health or substance use services.
Yeah, well, this has been very enlightening for me. So I really appreciate you taking the time to do a podcast with me. Is this your first or is this your second? I don't remember.
This is my second. I did one more back in the fall.
Okay. Yeah. So, I know this is, something I've been doing for a couple of years, but this was great. This was really fun to learn and dive deeper into this, especially as these reports are going to come out every year. So it's important stuff for us to know. So this has been great, Bryan. Thanks so much for joining me today. And hopefully our audience finds this super helpful. And obviously, if you have questions or need assistance with your NQTL comparative analysis, you know where to find us. Thanks again and have a great day.